All right, well, good morning, everyone. I'm really excited to be here. Thank you, Dr. O'Brien. Like he said, I am one of the PAs in the APP Neurology Residency Program, and I have just a quick case to share with you all. So this patient is a 29-year-old young woman, no real major past medical history, and she presented to our practice for 10 months at that point of neck pain with electrical sensations that would run down both of her arms. And she really experienced this for the first time. She was an avid athlete before this, and she first experienced this acute onset neck pain when she was lifting weights. And ever since that, she had pretty much exclusively this electrical pain that ran down both of her arms, maybe a little bit more into the right when she would extend her neck, and maybe a little bit of rotation to the right with that, but mostly neck extension. She had seen somebody else for this, and this story of a positional neck pain with radiating pain down the arms kind of triggered a reminder of the Lermite phenomenon. And this actually prompted a multiple sclerosis workup. And this patient does actually have a family history of MS, and this all seemed to fit. And she underwent a standard cervical MRI with and without contrast, and also of the brain. And it was negative for anything demyelinating, anything obviously structural that would have been causing this. And it was kind of unclear what was to happen from this. She underwent an EMG, nerve conduction study of the upper extremities, didn't find any evidence of like a radiculopathy, checked her vitamin levels, like we typically would. Maybe she had a high B6 in the past, but that didn't seem to be a leading issue now. It has resolved. And this poor patient had gone through so many rounds of physical therapy, nerve blocks, epidurals, had tried medications like gabapentin, Lyrica. Nothing was working for her. And so she presented to our practice for another opinion. Her exam was overall really just non-focal, not remarkable. She did also experience this pain. We put her in the position and she had the pain again. Maybe she was a little bit brisk through her reflexes, but overall nothing that was really standing out on the exam. And so where we went from here is, well, the thought was, if this patient is exclusively experiencing pain in one position, can we see what's happening on MRI in that position? And so we collaborated with the neuroradiology team, and they said, okay, let's give it a go. Let's try to get a positional MRI of the cervical spine. And what was found was actually kind of remarkable. When you compare to the neutral positional MRI on the left, and then the next image on the right is her in the position that was causing her pain, causing this radiating pain. And what you see when you do a positional MRI is that her ligamentum flavum is buckling every time she extends or rotates her neck. And so that, compared with just enough of a herniated disc in C7, is compressing the cord and causing her symptoms. And you never would have known that in just this plain cervical non-positional MRI that would have been missed. So kind of this reminds us of the Lermite phenomenon, the Lermite sign. Everyone seems to be fairly familiar with this, pretty much jumps to MS as a leading cause of this sign. And that's a very fair way to think. But to remind us what this is, the Lermite phenomenon is a transient phenomenon in which some sort of neck movement results in this electrical shooting pain down the upper extremities. This can happen in a couple different ways, actually. It's typically with neck flexion. That's what we think of most. But you can also have a reverse Lermite when you have symptoms elicited by neck extension. And I saw that you can also have an inverse Lermite, which is when you have upward moving paresthesias, which is kind of interesting. Some history about this sign. So in 1924, Jacques-Jean Lermite was the first to detail a patient with multiple sclerosis and this sensation, and wrote up a case scenario about it that started this correlation between the two. There was actually a study done in 1982 that found that 1/3 of those patients that were reviewed had a positive Lermite sign. But MS is not the only thing. Obviously, there are other demyelinating conditions. And so in 2014, a study was done, a cross-sectional retrospective, comparing MS patients and NMO patients to see the prevalence in these two conditions. And there were actually a higher percentage of those surveyed NMO patients that had a positive sign compared to those that were surveyed with MS, which is interesting, but it's just great to consider multiple conditions. And that's one of the takeaway points here, is that when you have somebody describing this phenomenon, we have to consider more than just demyelinating disease. Lermite himself actually theorized that this sensation, this phenomenon was caused by medullary lesions and a stretch or trauma to that dorsal column, that hyperexcitable dorsal column. And we still really consider that today as this hyperexcitable, the stretch of hyperexcitable dorsal column. Obviously, we know that many things can affect the dorsal column besides demyelinating disease. But when you have somebody with, especially I would say with a reverse Lermite, considering extrinsic causes or compressive causes becomes very important. So I just wanted to share this case to kind of review or remind us to be more broad when we're considering somebody that kind of sparks this reminder of the Lermite phenomenon, to be more broad in what we're considering. And a huge takeaway for us today too is that is this concept of a positional cervical spine MRI. And I want to stress that this is not a routine order. This is not something that we can just pull up in Maestro and just do kind of routinely, but this stresses the importance of communicating with our neuroradiologists. We have great resources at our disposal, and working with them and collaborating with them to approach our patient's problem can actually lead to something really innovative like this. So I just wanted to open that door, and that is all I have for you. So thank you.
Thank you very much, Ashley. So I'm going to turn it over to Sujay, who's going to introduce today's Grand Round speaker.
Thanks so much, Rich. I am thrilled to introduce Dr. Matt Khayata. So Dr. Khayata, just as far as background, did his undergraduate education and medical school education at Florida State University, and then joined us here at Duke. He's been with us for the past 5 years, where he's done his pediatrics residency and child neurology training. He has had a busy time since he's been here. He's completed the medical education leadership track, an amazing program regarding education and mentorship here at Duke. He participated in the American Headache Society resident education program. He's had numerous peer-reviewed papers, abstracts, posters, and invited lectures. This year, despite being incredibly busy, he served as our administrative chief. And on a personal note, I found him to be just this amazing mentor, leader, and advocate, and has really pushed us all forward in our division regarding his QI initiatives, which we're really appreciative of. Next year, he's going to be joining Prisma Health in South Carolina. He's going to work alongside Cecilia Fernandez, one of our wonderful alumni. And so we're really excited about that. His lecture today is Beyond Pain Control, Outcome and Treatment Preferences in Pediatric Migraine. So Dr. Khayata, turn it over to you.
Thank you, Sujay. Can you hear me okay? Let me start sharing here.
You're fine.
Well, are we good in terms of the presentation? Can you see just my slides?
Yep, we're good.
All right. Thank you, guys. Thanks, Dr. O'Brien. Thank you, Sujay. And thank you, everyone, for giving me this amazing opportunity. It's great to see all the adult colleagues on this platform. Yes, I am still around, even though I haven't seen you in what seems like a few years now. But I'm definitely honored to kick off this Chief Grand Rounds series. And it's a privilege to talk about some research that I've had an opportunity to participate in for the last year and a half or so with Dr. Monica Lemon and an amazing research team here at Duke, and both actually throughout the country as well. But like Sujay said, my talk is titled Beyond Pain Control, Outcome and Treatment Preferences in Pediatric Migraine. Before I get started, I just want to say that we're very excited that this work has been, as of very recently, been accepted for publication at a major headache journal, as well as has been selected by that journal to participate in a podcast, which Dr. Lemon and I will be doing actually in 2 weeks. So hopefully if you're excited about this work as us and you have more questions or would like more details, there'll be more information available to you guys in the next weeks to months. So my disclosures are that this project was funded by the Burroughs Wellcome Fund and Global Pediatric Clinical Trials Network. This is my very basic outline, but basically I'll talk to you about pediatric migraine and give you a little bit of that background and what prompted us to kind of think about important questions and do this study. I'll talk about the objective of our study and then just kind of go into what we did, what we found, and then what we thought of our findings. And then finally, summarizing things and just talking briefly on future directions and where I think we can go from here. So we all know that migraine is common. I don't think I need to provide a group of adult neurologists that background, but I don't know that it's really recognized how common migraine is in the pediatric population. And in fact, 1 in 10 children and adolescents experience migraine. And unfortunately, those individuals have a lower quality of life. They perform more poorly academically when compared to peers who don't have migraine. And they also have what we call impaired socialization. This is a significant, this disease carries significant burden for the patient as well as economically. And many of these children and adolescents who have migraine will continue to experience this into adulthood. So it's very important that we continue to think about this because it may span the entire lifespan for the patient. Unfortunately, there's very limited evidence-based therapies for pediatric migraine. We do have therapeutics out there, but there's a high placebo rate, and that high placebo rate has made it very challenging to determine their true efficacy. And because of this, the regulatory bodies such as the FDA, the European Medicines Agency, the EMA, appropriately require that more therapeutic safety and efficacy studies are completed so that we can determine what is actually effective in this population. Those same regulatory bodies, including the International Headache Society, have published very comprehensive guidelines to help improve the quality of both acute and preventative migraine, clinical migraine trials. Of note, there's one guideline that's been published that specifically addresses pediatrics. Otherwise, all of these guidelines are adult focused. These guidelines specifically comment on outcomes and endpoints that are recommended by the experts. And I want to spend a minute or so just commenting on the 5 major ones, because I'd like you to keep those 5 things in mind as we go through the talk. But the endpoints and outcomes that are expert consensus based include pain freedom at 2 hours, the absence of the most bothersome migraine symptom. This is actually a co-primary or secondary endpoint, a change in migraine days, a change in moderate or severe headache days, and a 50% responder rate. Despite having those outcomes and endpoint recommendations, as well as the guidelines in place, there's been many systemic reviews recently that have highlighted a significant variability in the way studies are designed, as well as the outcomes and endpoints and patient-reported outcome measures that are being studied in these acute and preventative migraine trials. There's absolutely no doubt that the 5 outcomes that I just mentioned are extremely valuable. But what we're starting to understand or recognize is that they may not fully capture the true burden of migraine, nor be fully accepted by the stakeholder. And we know from personal experience as doctors, as well as literature, that direct input from stakeholders is a very valuable thing. And understanding their experiences, their perspectives, their preferences about what's most important to them can be used to inform research, deliver healthcare more efficiently or better, and inform policy as well. And despite the significant burden of migraine in children and adolescents, which I just described to you, little work has been done overall to determine what outcomes matter most to pediatric patients and their caregivers with migraine. So the objective of our qualitative study was aimed at describing the perceived treatment preferences and quality of existing outcome measures among children, adolescents, and caregivers affected by migraine. We recruited participants from the Pediatric Migraine Registry. This is a really cool registry, which was a multi-center prospective registry of children and adolescents aged 4 to 18 years old. All of these individuals had a diagnosis of migraine with or without aura, and that diagnosis was based on the International Classification of Headache Disorders, 3rd edition criteria. The registry itself enrolled 202 patients from 19 sites in 15 states within the US. I know that 202 sounds like a low number. It is, and that was actually the target number for the migraine registry. And I can't really comment further than that. That was just their target number. Our Duke Clinical Research Institute, the DCRI, served as the coordinating center and operationalized the registry. The registry was additionally overseen by a multidisciplinary steering committee, which included members from Duke, as well as headache experts all throughout the country. We used a stratified purposive sampling technique to recruit patients of diverse ages and migraine chronicity. And we separated out those patients into episodic versus chronic migraine. We then completed semi-structured interviews with the patient and one caregiver separately. Interviews were conducted and audio recorded via an encrypted virtual meeting and were completed by 2 trained interviewers. Questions that we asked targeted treatment preferences and perceived quality of existing outcome measures. We had questions that were targeted based on the child's age. So for example, children were considered ages 4 to 9. And an example question that we might ask them was, when you have a headache, what do you do to help you feel better? Or have you ever taken a medicine for your headache? And if you did, how did that make you feel? Our adolescent questions were for those ages 10 to 18. They were a little bit more detailed and specific. We would ask again, have you ever been treated for your migraines? If yes, have you taken a daily medicine? And if they answered yes to that, we might ask them then, how do you know that it's working, for example? We also had specific questions for parents as well. Our team reviewed the literature relevant to migraine, treatment outcomes and outcome preferences. And because there's a lack of an established framework for the outcome preferences in pediatric migraine, we developed a novel code book to characterize patient responses. Again, like I mentioned before, we conducted these interviews, and all of these interviews were transcribed, de-identified, and independently coded by 2 team members using a conventional content analysis approach. And using this coded data, we were able to identify themes and some sub-themes, which I'll be commenting on as we progress through the talk. We used a qualitative analysis software known as NVivo, and that was used to label, organize, and analyze our codes. So briefly here, we see just a brief overview of our results, and I'll show you our table 1 and 2 next. But essentially, we enrolled 30 dyads and completed 59 interviews. The reason why there's 59 and 29 here, as you can see in the results, is that 1 parent declined their child's interview and 1 parent cared for 2 children in the study. The individual that had 2 children actually completed 2 distinct interviews about each of the child's experiences. So here's our table 1, which represents child and adolescent characteristics. I know this is a busy slide, but I've tried to highlight some of the things to focus your attention on in red. The median age of the participating children and adolescents was 15 years with a range of 9 to 18 years. Children and adolescents experienced a median of 13.5 headache days per month. We also collected information about migraine disability through the Pediatric Migraine Disability Assessment, the PED-MIDAS, similar to what is used in adults. To give you some reference here, the PED-MIDAS is ranged from 0 to greater than 50. 0 to 10 is little to no disability. 11 to 30 is mild. 31 to 50 is moderate, and greater to 50 is severe. So on average, our cohort had a mild disability, but there was a significant range, as you can see there, ranging from mild to severe. We also asked about the number of preventative migraine therapeutics that were trialed, as well as acute migraine therapeutics. And of note, it's not in the table 1, but the majority of participating caregivers identified as mothers with a median age of 44 years. So here's our table 2. Our participants were asked through the questions that we asked to reflect on the outcome that mattered most to them pertaining to acute and preventative medications. And again, these responses were categorized using that conventional content analysis approach that I mentioned earlier. So this table 2 represents the code frequencies of each derived code. Some of the caregivers and children or adolescents did not answer these questions, primarily due to limited comprehension, particularly the very younger children, or just lack of a clear preference or lack of an experience with a specific medication. But in regards to acute medications, when describing the most valued feature of acute medications, participants most often cited a reduction in pain intensity, in pain severity, which they characterized as either pain resolution or a reduction in pain intensity. They additionally valued the absence of side effects and valued specific medication attributes, which, for example, included better taste or an easier or different route of administration. And some of those things here are highlighted in red. In regards to the preventative medications, we asked them similar questions, and when describing the most valued feature of preventative medications, the participants most often cited the absence of side effects or a reduction in headache severity, which again, they characterized as pain resolution or a reduction in pain intensity. Other things that they valued from preventative medications included a reduction in headache frequency, medication attributes, like I mentioned a second ago, and the improvement in non-pain symptoms, which we'll talk about more in detail in a little bit. And again, highlighting in red some of the things that I just commented on. So based on that data that I just spoke about, we were able to determine themes and sub-themes. These are the 3 primary themes that emerged from our data, which we labeled as the following. Theme 1, symptom relief, looking beyond headache resolution. And that has various sub-themes. Theme 2, trade-offs between side effects and relief. And theme 3, child-centered treatment. For the rest of the talk, I'm going to go through each theme, comment on each sub-theme, and provide you with some powerful quotations from our participants that will hopefully demonstrate their feelings about these things. So theme 1, symptom relief, looking beyond headache resolution. In this theme, participants described the value in efficacy outcomes outside of just complete pain relief, and that included a modest reduction in headache intensity, as well as improvement in non-pain symptoms. So in regards to hard to imagine relief, which is one of our sub-themes here, many of our participants really described how it was so hard to imagine pain relief, and they often described a persistent, debilitating pain. When discussing what treatment outcomes mattered most, one adolescent who had episodic migraine shared with us, well, I mean, a cure would be great, but that's a wish that's not fulfilled. In terms of reduction in intensity, many participants shared that while complete pain relief was a worthy goal, a reduction in intensity would be just fine. In fact, many of our participants believed that this was the most important medication goal. And to characterize that or explain that further, one adolescent shared with us, my baseline's a 7 out of 10 on a daily basis. I would be so happy if my headaches were at a 2 every day. In regards to pain resolution, many participants focused on reduction in pain intensity, like I just mentioned, but others, in fact, did comment on the benefits of what it would be like to have complete pain resolution. And one adolescent who had episodic migraine told us, I think that it should get rid of the problem. So not just reducing it, but also getting rid of it. And then finally, reduction in non-pain symptoms. Several of our participants really focused and shared that medication should address non-pain symptoms as well as the head pain. And they really cited that there's significant challenges associated with nausea, light sensitivity, visual symptoms, fatigue during one of their migraines. One parent shared with us that when you're dealing with migraine, it's not just pain. There's all the other side effects that are associated with it, be it visual changes, the sound sensitivity, the light sensitivity, the nausea, the pressure, the almost a full onset of depression set in with each individual headache. Theme 2 is our major theme. Theme 2 is trade-offs between side effects and relief. And here participants described a cost-benefit analysis that can occur with headache treatment and acknowledged that the impact of treatment side effects on their daily lives. When commenting on the role of side effects, participants discussed the role that drug side effects have when considering a given treatment. Many of them discuss side effects as replacing their pain with just an alternative symptom that was as bad as the headache itself. And some participants discussed the impact of side effects on drug adherence. So for example, one mother shared with us that of her adolescent with migraine, he is having a lot of side effects and he can't stand it. He literally told me, I'm only taking half a dose. He's 15 years old. I can't shove the pills down his throat, and I'm not the one dealing with the side effects. In regards to side effect impact on daily life, when discussing this, participants discussed how side effects truly do have an impact on daily lives, including their ability to attend school, participate in sports, or even just think clearly and get through their day. And one adolescent summarized this by saying, I'm so overworked and stressed worrying about school. I really need a medication that doesn't affect any sort of like thinking ability. I mentioned that participants described this real-time risk-benefit analysis in which they balanced the potential for relief with the potential for side effects. And some participants were willing to tolerate more side effects if there was a higher chance of pain relief and or headache prevention. So for example, an adolescent shared with us that how they would actually tolerate side effects if a medication were truly effective. And he or she said, like if my legs were jittery, but it stopped my migraines and headaches completely, I'd deal with the jittery legs. In contrast, however, some participants prioritize the absence of side effects above efficacy. And one parent of an adolescent shared with us that say medication made her feel like super, like her headaches were better, but it also makes you weigh 83 pounds. I believe I would probably would have picked a less efficacious medication without that side effect. And finally, theme 3, which is child-centered treatment. And here, participants described medication attributes that were important for children and adolescents, including fast onset medications, age-appropriate routes of administration, as well as the need for more pediatric-specific safety data. Many caregivers described the need for medications to be fast-acting, with a focus on how this was of higher relevance to children than other populations. For example, one parent shared that there's a significant burden associated with watching her child suffer. And she said, I think as a mom, as fast as possible is good because it's hard to watch your kids suffer. Caregivers, children, and adolescents all cited the need for alternative formulations and really focused on routes of administration as an important factor here. They desired liquid transdermal patches or just better tasting formulations, for example. And they feel like this would potentially change the way that they take their medications and make things much easier. When asked about the most important feature of a medication, an example quotation of a mother was making it palatable for children. She later expanded on that and said that a patch would be fantastic. We could just stick it on her and move on with our lives. And finally, investment in pediatric research, pediatric focused research. Some caregivers cited the lack of pediatric specific research as a barrier to the development of effective treatments for their child. And one parent shared with us that it's just, we need more studies, and we definitely need more studies in pediatric patients because there's not enough. And that was a parent of a caregiver, a caregiver of an adolescent with chronic migraine. So I hope those quotations that I chose, there's more in our paper, but those are strong ones in our opinion that kind of highlight these concepts and are true representations of what the stakeholders are feeling about these things. So what can we conclude and what can we talk about from these findings? At least in this cohort, stakeholders, which are children, adolescents, and caregivers, value outcomes that, in addition to the traditionally accepted ones that I mentioned, including the ones that are studied in major clinical trials and recommended by the experts and by the regulatory bodies. Again, these are extremely valuable. There's no doubt that they are, but these traditionally accepted migraine endpoints and outcomes may not truly capture what's most valued by stakeholders. Our cohort did endorse the importance of pain relief, but they also prioritized other things, including the absence of side effects, a reduction in pain intensity, and other key medication attributes as their most preferred treatment outcomes, which are clearly a little bit different than what is currently being recommended for studying. Many of our participants, unfortunately, found it very hard to imagine any sort of relief from migraine pain. And this finding just underscores the importance for sustained investment in developing treatments to improve outcomes for pediatric patients and adolescents with migraine. Like I mentioned, there's no doubt that headache freedom is a worthy and very valued endpoint. In fact, many of our participants think that that's extremely important. But our results also raise the possibility that reduction in pain intensity alone would be just as appropriate outcome that's very valued, that would be very valued by stakeholders. And this is also the case in other chronic pain conditions. And a reduction in pain intensity in chronic pain disorders is something that is well documented in the literature. And this finding supports that. Stakeholders also shared that there is a significant challenge that is associated with non-pain symptoms, the nausea, the vomiting, the photophobia, the phonophobia, et cetera. And this indicates to us that there really is a need for clinicians, us, to assess the burden of these non-pain symptoms and to potentially counsel caregivers and the patients themselves on how best to mitigate these things if possible. So understanding that and learning that from this group of participants actually supports that co-primary or secondary endpoint, which is the reduction, improvement, studying the improvement in the most bothersome migraine symptom is very important. That is very important for our stakeholders here, and it supports the inclusion of that outcome to be studied. Participants also acknowledge the impact of medication side effects on daily life, as I mentioned. And unfortunately, a significant side effect burden results in impaired ability to succeed in school, limitations in participating in sports, or otherwise just functioning on a daily basis. As I mentioned, many patients in our cohort described a real-time cost-benefit analysis in which they balanced the potential for relief with the potential for side effects. And this willingness to trade off efficacy to avoid certain adverse effects supports existing data from adult migraine populations, something else that's very well documented in the literature. And what this suggests is that future work should probably characterize how distinct side effect profiles could influence stakeholder preferences and adherence. I spent a few minutes talking about how medication attributes were, especially time to onset and route of administration, were very important, particularly for pediatric patients. And this highlights the need for sponsors and researchers to prioritize the development of both pharmacologic and non-pharmacologic treatments that include age-appropriate administration modalities, particularly for those intended to treat the very young children, because oftentimes they're the hardest ones to treat. Some good examples of this in other chronic conditions, for example, include stimulant medications for ADHD. There are numerous formulations, as many of you may know, that allow for informed clinical decision-making, as well as individualized treatment approaches when it comes to treating ADHD, just given how many options there are to treat that condition. There are similar pharmaceutical approaches that are used in other chronic conditions, for example, like tics, or even epilepsy, just given how many medications there are and how many options that there are. So I think adopting this type of approach to treat migraine in youth may result in improved medication adherence and just long-term outcomes in general. So of course, no study is without limitations, and here are some of the limitations that we would like to comment on in our study here. While participants were recruited from a multi-center prospective pediatric migraine registry, findings may not be generalizable outside of the United States. Furthermore, the majority of our participants, like you saw in our table 1, were adolescents and mostly white. And interviewing a more diverse population of children and prospectively collecting more detailed information about socioeconomic status, for example, would have broadened our understanding of their outcome and treatment preferences. And then finally, interviews were audio recorded, so nonverbal information was not captured, which certainly could have been helpful or had yielded additional information. So in summary, our results highlight a unique opportunity to design patient-centered clinical trials, develop drugs, and support product labeling that is in alignment with the outcomes valued most by children, adolescents, and their caregivers who unfortunately have migraine. And integrating patient-centered outcomes into clinical trial designs may lead to the development of therapies that better meet the needs of the stakeholders, which is extremely important. Future work should be aimed at better understanding the migraine experience, as this may identify additional outcome measures most meaningful to stakeholders, and also characterize differences between caregivers and youth. We actually have a manuscript outlining this analysis, which is currently in review. So hopefully, maybe next time we can talk about that, and you can look forward to those results. That paper was written by 2 wonderful medical students on our team, and it's very great work. So I'd just like to spend a few minutes acknowledging some very important people. This is our research team, Dr. Monica Lemon, Dr. Christoph Hornick, Amy Gelfand, Christina Spurker, some of the 2 leading pediatric headache experts in the country, as well as everyone else on this list. Thank you so much for this amazing opportunity. It's been a phenomenal experience and a great learning experience from all of you. I can't end this talk without acknowledging my Duke Neurology family. I truly consider this a family, and I'm going to miss you all so much. I can spend an hour talking about everybody on this list, which I will not do, but everyone here has impacted me in so many ways, has allowed me to grow personally and professionally. And I feel very confident leaving Duke as a good neurologist. And I thank everyone for that. Dr. Makati, thank you for all your support and mentorship. Dr. Zafar, he took me under his wing from day one before I met anyone at this program. And he's an amazing mentor. We've become great friends. And thank you, Dr. Zafar, for everything. Sujay, all your advocacy and hard work for us. Carolyn, the best teacher, amazing neurologist. Dr. Lemon, thank you for all your research and your teaching and letting me join your team. Dr. Rathke, Dr. Warner, everyone else on this amazing team, thank you. It's been amazing. And then last but not least, I have to thank the heart and soul of Duke Pediatric Neurology, my very amazing friends and co-fellows, Kate Taylor, Kaylee Manny, Lauren Chamberlain. These three people are just amazing people. They're extremely hardworking. We are such a good team. And I can't think of anyone else that I would have liked to do these last few years with. And you all are amazing neurologists, and I can't wait to see what you all are going to be doing in the future. So that's my talk. I hope you enjoyed it. I'm happy to answer any questions if any came up, but thank you so much for giving me this opportunity, and I hope you enjoyed it.
Thank you, Matthew. So if anyone has questions, just either put the question in the chat box or just put your name and we'll call on you. But Matthew, I have a question of things going in two directions. What age do migraines really become common in kids? And at what age do pediatric neurologists start using adult drugs in children?
That's a really good question. I think we're learning more and more that migraine is becoming, so I don't have and if any of the headache specialists on the call, please jump in, but I don't have an exact age in which migraines become common. But I think in general, we're learning more and more that migraines are there at early ages. Sometimes, you know, as adult or as child neurologists, when children have just bizarre, funny spells that we can't really explain for other reasons, sometimes we are diagnosing them with migraine. And like in our study here, we had kids as young as 4 years old, and I've definitely seen younger who have been diagnosed with migraine. I think just more information is needed long term, but to answer that question, I don't know the exact age, but it's definitely becoming, we're definitely recognizing it earlier and earlier. In terms of the treatment, you know, we typically use Topamax and we typically use amitriptyline as kind of preventative prophylactic things. We also use some of the triptans, which are FDA approved for pediatric migraine. Now that the CGRP class has come out, there is limited data for pediatrics, unfortunately still, but I believe we are starting to get away with prescribing that in early teenage years. And a lot of that depends on kind of insurance approval and whatnot. I don't personally have too much experience with that, but I think we are trying to start some of those medications sooner than later as well, just because they're effective, but they're not just always approved. So long story short, from a treatment standpoint, it's often very difficult because we don't have a lot of options, and it's mainly because we just don't have the approval or the research or data to support the use of some of the adult things. So I hope that answered some of your question, Dr. O'Brien, but and if any other headache folks on the call want to comment on their experiences with that, please feel free.
Yeah, Tim, do you want to make a comment?
Yeah, sure. So the population surveys tell us that 6% of children have migraine headaches. Diagnosis is often delayed because they typically present with non-headache complaints, so it's really hard to pin that down sometimes. As far as medications, my experience with both kids, teenagers, and talking with other pediatric neurologists is that there's so few drugs that have specific data for children that frequently they're using adult meds in kids because we don't have a lot of other choices. And the data for drugs in adolescents, as Matt indicated, is that the studies are confounded by placebo-controlled trials that on the one hand show a drug works, and then on the next trial shows that it's no better than placebo. So it's complicated. But I would say early use of the same drugs we use in adults is relatively common in the peds world.
But the CGRP drugs are probably being blocked by the insurers, I guess.
I don't know about kids under the age of puberty. I know in teenagers we're frequently able to get them because they're substantially less expensive than drugs like Botox. So the insurers aren't entirely blocking them for teenagers.
Okay. Mohammed, you had a question or comment?
Yeah, first I'd like to congratulate Matt on a great grand rounds. I mean, he was talking like a lifetime expert in headache with poise and knowledge and comfort. Just amazing. I felt like I'm listening to an international expert on headache. So this is great. And this is not surprising. Matt really puts his heart in everything he does. And he's not graduating as a good neurologist. He's graduating as a superb neurologist. So it's been a pleasure to have you. He has so much dedication and so much commitment to the excellent care that he gives to his patients. So we'll miss you, but you will not be very far, and I'm sure we'll share patients, and perhaps you will be coming back to Duke sometime. I have a question regarding headache and symptom-free days. How did that rank with respect to the other parameters that you looked at, like severity and side effects and so on and so forth?
Let me pull back. I accidentally unshared my screen. Can you all see it okay?
Yes.
I don't know that we, let's see, I don't know that we actually got enough data for that, Dr. Makati, in terms of, reduction in headache frequency here in terms of acute and preventative migraine treatments was something that was clearly valuable to them. And I'm sorry if I'm not understanding the question. And if Monica, if you're on and you want to jump in with this one.
Yeah, I mean, sometimes in these paroxysmal disorders, the symptom-free days turn out to be significant for the patient. Sorry, Monica, please go ahead.
I think that's a really great point. And, we derived these categories inductively, meaning that we used what people said to define the categories. We didn't provide prompts. And interestingly, that did not come up. Reduction in frequency did, but unlike metrics that are commonly used in trials, that didn't arise here, but I think is captured under the umbrella of reduction of headache frequency.
Mm-hmm.
Okay, Carolyn Pizzoli, you wanted to make a comment?
I was just in regard to the use of some of the adult medications in pediatrics. I think in the very young school-age child age range, I think often, and I don't think it's just me, we'll tend to use the ciprofloxacin initially to avoid some of the side effect profile and lack of equal data. especially as you all were alluding to some of our acephalgic migraine variants in that age group. Cyclical vomiting, the positional vertigo kind of types of syndromes tend to have some effect with ciprofloxacin, and then the propranolol as well.
Yeah. All right, looks like everything else, Matt, is just superlatives. Congratulations, excellent. And thank you for doing grand rounds, and we look forward to great things from you in the future.
Thank you so much, Dr. O'Brien. Thank you, Dr. McCarty. Thank you, Dr. Lemon, Carolyn. I already said thank you before, but thank you again. Y'all are truly my family, and I'm gonna miss you all. But thank you so much for this. I had fun, and I appreciate y'all listening.
Thank you, Matt.
Thanks.
Great work.